Thank you, ZSOG, for offering me this opportunity to make a presentation on decentralized obstetric care and gynecological care, and we are looking at it from the view from Victoria Falls. I will give you my outline as below. I'll start with the background. Obstetric services being offered, gynecological services, the surgery being offered. Then I'll look at the mentorship program, the achievements we have made so far, the challenges we have experienced, and our recommendations. So a little bit on the background. The Ministry of Health and Child Care came up with a plan to decentralize specialist care to the provincial and to the district level. After successful decentralization to the provincial hospitals, it meant this was also possible at the district level. The Department of Family and Child Health thrust was to reduce maternal and perinatal mortality and morbidity. This would be achieved through capacity building, specialists stationed in the provinces and the districts to provide specialized care, training, and mentorship. In turn, that would reduce the transfers to the central hospital, and in this way, decongest them to cater for the critical cases. In 2015, at the 68th World Health Assembly, WHO noted that surgery and obstetrics were the most neglected areas of healthcare delivery. So inculcating basic surgical obstetric services in primary healthcare would enhance universal health coverage. Earlier on, Ethiopia, Nigeria, and many West African countries had already started decentralization and strengthened this after that assembly. Zambia immediately, say 2 years after the assembly, they embarked on an implementation of their first ever national surgical obstetric and anesthesia strategic plan. And it was started in 2017 and should be fully fledged by 2021. And this was envisaged to strengthen countrywide mentorship for surgery, obstetrics, anesthesia to the district level. So we are not unique. Others have done it. Others are starting to implement it. And Zimbabwe has just started also to do the same. Zoning back home. So this is the map of the district where we are working from. So for many people, they didn't know this, but Victoria Falls is under one district. And you can see the majority of the district is the national parks. And then Victoria Falls is just that at that right corner there, which is at number 2. The rest there are the centers that are serviced by the district. There is HWANGE Hospital there, and closer to it, there is St. Patrick's Hospital. It's a mission hospital. And then we have Victoria Falls Hospital. And then we have 2 private hospitals in Victoria Falls City or town, and then we also have clinics dotted around. We serve a population of 158,000 in the districts, that's the catchment area. And we also have clients coming in from other districts within the province. Our expected number of women of childbearing age stands at 42,664, with 5,689 expected deliveries. Coming back to zoning onto the hospital. So Victoria Falls Hospital was selected to be one of the pioneer districts for the decentralization process. It was also selected alongside the central hospitals to be one of the super specialist hospitals by the government. And it's a small hospital with 40 bedded, with a 6-bedded ICU. It is a vibrant workforce with a laboratory and radiology. And we also have support from the private sector in terms of the lab and radiology services. We have the PSMI offering the same. We have the Lancet Laboratories offering the same. So we are well covered in terms of the investigations that we would want to do. We have sufficient capacity to offer specialized care, starting with obstetrics, and we should be able to offer the other specialties as well. That's a picture of the Victoria Falls Hospital IC unit. It has 6 beds with 4 ventilators and 2 pediatric ventilators. It's quite impressive that such a small hospital has a nice ICU like that. However, we don't have an anesthetist here. We only have an ICN and some registered nurses also assisting. But yeah, it is working well for us and it is serving the purpose. I came to the province and to the hospital in last year, in 2019, and we started to establish the Department of Obstetrics and Gynecology at the Vic Falls Hospital. So we have the OPD, we have the maternity wing, we have the cervical cancer screening unit where we do our pap smear, VIAC, and lip, as well as the gynae wards and postnatal wards. What are the services that we have successfully started to offer in the hospital? We do all the deliveries. So uncomplicated deliveries are mainly conducted by the midwives, whilst the complicated cases are managed by the doctors and the midwives and the specialists. We've started in 2019 to manage severe preeclampsia, with cases which were being referred to BLAHWAYO before we embarked on this. We also have a neonatal unit where we admit mainly the preterm deliveries, and it is working well. We have several incubators, but because of the temperatures in Victoria Falls, we have never needed to use the incubators. All our neonate or preterm babies do very well with kangaroo maternity care. We've successfully done the dystocia, breech deliveries, and the trial of labor after cesarean section. We also manage patients with complicated medical conditions, and we have 2 ultrasound scan machines at the hospital. One which is stationed in the labor ward. We do labor ward scans, and we also have one in the OPD where we do our antenatal clinics. We have a radiographer, sonographer at the hospital who also does ultrasound scans and x-rays. In the theater, we have managed to do multi-orders previous cesarean sections. So previously, all patients with 2 previous cesarean sections, 3 previous cesarean sections will be transferred to BLAHWAYO. Now we are doing all these cases at the hospital, and we've managed to train the GMOs who are available to also do 2 previous cesarean sections. A point where I would feel that we should be able to allow our SRMOs to do these cases, because most of them, when they come here, they are not comfortable to do 2 previous Caesar. I think we need to change our curriculum from the training to be able to have our SRMOs participate in doing multi-order previous cesarean sections. We have patients that get to theater for failed TOLAC, antepartum hemorrhage, mainly abruption, and placenta previa. All these cases would have to be transferred without a specialist care. We also do patients with eclampsia and those that have medical conditions in pregnancy. We also do EUA for patients that have PPH, post-normal delivery, where we do then EVAC, balloon terminate, repair cervical tears, repair 3rd and 4th degree perineal tears in theater. We've also conducted laparotomies in patients with PPH that needed then to be followed up with breast sutures, including billing, uterine artery ligation, and we've done peripartum hysterectomies at the institution. In terms of gynae, we have managed to do cervical cancer screening through VIAC, pap smears, and we do cryotherapy. And recently we received a machine from the ministry to be able to do LIP. So this is going to start, it was only disturbed by the COVID outbreak, but we should be able to offer LIP services. We were referring our patients to Bulawayo for LIP. And we actually had one patient who ended up at Gweru and had a LIP from one of our doctors, they have Dr. Mkwembi. But now we are offering these at our hospital. We also manage early pregnancy complications, including miscarriages, molar pregnancies, ectopic pregnancies. I should hasten to say all the GMOs that we have in our institutions can now manage ectopic pregnancy, cases which they were referring before the decentralization. And this is very important. Why? Because the distance from Victoria Falls to Bulawayo can take up to 6 hours. And this was quite problematic for the patients because some of them would deteriorate before they get to the referral hospitals. So now the community is very happy that we have those services available locally. We also manage to treat gynecological infections, and we offer family planning services, including BTL and fertility counseling. So, and investigations needed for fertility management. Gynae operations, we do suction curettage, we do myomectomies, total abdominal hysterectomies, vaginal hysterectomies, although we've just done 3 at the moment of the vaginal hysterectomy. We do anterior colporrhaphy, and we do laparotomies for the ectopic pregnancies. We've done a few pelvic abscesses in referred patients and ovarian cysts. This is a combo which is showing some of the gynecological procedures that we have been doing at our institution. On the left here is one of the hysterectomies that we did very much into the beginning of the attachment here. So this was in March 2019 when we did our first TAH. It was a really huge fibroid uterus, multifibroid uterus, which was measuring up to 36 weeks. So it was a successful hysterectomy. This is a picture which is indicating one of the cases that we did for myomectomy. And one of the GMOs there, Dr. Jeans, was also being mentored. Also, although they were just work as assistants. So we don't have the specialists, other specialists here. So the GMOs, we had 5 of them in the years of 2019, and they all participate in rotation to assist with gynecological cases in theater. That's one of the other cases that we did. On the left is a ruptured ovarian cyst in a woman who presented in severe sudden onset abdominal pain with no history of amenorrhea. So having ruled out an ectopic pregnancy, we did a scan which noted that she had a huge right-sided ovarian cyst. So when we opened, we noted she had a chocolate cyst which had ruptured, and the histology came back benign. Again, it was the beginning of the year, as shown on the right side, is an abdominal ectopic. This was a 23-year-old who had presented with severe abdominal pain after 18 weeks of amenorrhea. So this was an 18-week gestation pregnancy, and the scan had revealed an abdominal ectopic which had ruptured. So when we opened, we noted that the ectopic was actually in the abdomen with the placenta embedded on the greater omentum and the large bowel. We successfully managed to do the case, and the patient recovered and went home. So we're going to look a bit of statistics from the time before we started up to the time up to date. So here, because we are working as I'm working as a provincial obstetrician and gynecologist, we look at the impact in the province and the impact at the hospital. So these are the deliveries, basically deliveries in the province and in the district. So on average, we have 3,700 cases being delivered every year at the hospital. And on average, it will be 22,500 in the province. So cesarean sections, before I go to that, the number of deliveries have not increased much, but they've sort of increased compared to the previous year at 3,772 at the hospital compared to 3,534 in 2018. And we are looking at even a higher figure during the year 2020. And we noted that the moment the community heard that there was a specialist in FIC4, so all transfers started to come in from outside the district and outside the hospital. Looking at the cesarean section, figures from 2017 to 2020, you can see that 2017 we had at the hospital we had 242 cesarean sections, 224 in 2018 and 240 in 2019. And by August 2020, we were sitting at 150. The cesarean section rate slightly, okay, we would actually say the cesarean section rate at the hospital almost remained stagnant. There was not much of a change, and it was around 22%. So the cesarean section rate has remained 22% for the hospital and around 8% for the province. Then what has been the impact of a specialist in the district and in the province? So in terms of perinatal mortality rate, you can see that for the hospital, we had 31 in 2017, 27 perinatal mortality rate. Then in 2018, 24, and then in 2019, it was 28. Then at the moment, we are sitting at 29. Then as a province, the perinatal mortality rate was 17 per 1,000 live births in 2017, then 18 in 2018. And then as of 2019, we were sitting at 19. You realize that there's not much decrease in the perinatal mortality rate in the years after the relocation. So we'll look at why have we not had much impact there. And yeah, we really feel that neonatal support is not very good in the whole province, in the hospital, in the whole province. And you would really want to have a pediatrician to be stationed in the province and the district hospital as well. We have adequate care for the neonate, preterm babies, but sometimes some of the procedures that will be needed for resuscitation and maintenance of a preterm baby may need the care of a specialist pediatrician. What about maternal mortality? So here, that's when we have seen probably the greatest impact of having a obstetrician in the province. So basically, there were 14 deaths in the province in 2017, 11 in 2018 and 2019, and at the moment, there are 7 deaths. So when we started, we had our provincial meeting agreed that we want to take the figures, because when you look at the figures here, we no longer talk about maternal mortality rate for our province. Our figures have been very impressive, and we have said we want to have single-digit figures for the year 2020. So as of August, we had a total of 7 maternal deaths in the whole province. And the Victoria Falls Hospital has indicated there we have not had maternal deaths after 2017. And only we had 1 case in 2017. So we really are impressed by what we are experiencing in terms of maternal death, and we are happy with the progress that we have made in training our DMOs in the province to reduce maternal mortality and morbidity. And we are hoping that by the end of the year, our figure will remain at 7, so that we have single-digit maternal mortality in the province. And then when we look at the transfers out, in 2018, there were 27 maternal transfers to Bulawayo. In 2019, we had reduced it to 17. And this year, so far, we are at 7. And then neonatal transfers were 15, reduced to 13. And at the moment, we are at 1. So we really, again, see an impact in the reduction of maternity transfers, and which we believe really benefits the community and benefits the government and benefits the institutions themselves, as they reduce the cost of transfers and inconveniences to the patients. In terms of research, yes, we also need to continue to do research so that we can improve the quality of care for our patients. We have started on studies to look at the maternal and perinatal outcomes associated with the use of traditional uterotonics. I will expand on this in the next slide. We're also looking at teenage pregnancies, the prevalence and outcomes of teenage pregnancies in Matabele in North. This is the whole province that we'll be looking at. And then we're looking at COVID-19 in pregnancy, maternal and perinatal outcomes. This is a study we realize we need to do and have our own outcomes in the province. However, the numbers are so few, so we really feel maybe this should be a national study, and we are engaging with the fellow obstetricians in the provinces to be able to conduct this study significantly with a proper sample size. Why we chose to have that first study there, we realize in this province, or not just the province, but even at the hospital itself, we have so many cases of patients that use the traditional uterotonics, the African Pitocin, and so many things, the elephant dung. So I was shocked when I came to the province and I went into the labor ward. I looked at the PARTOGRAPH. You would be shocked that this is a PARTOGRAPH that was plotted correctly, because there would be only 1 plot, or there could be just 2 plots, and the patient is delivered. So initially I thought, probably the midwives were not doing it correctly, until I did the examination myself and waited until that woman delivered. And I realized, the patients here do not follow the standard PARTOGRAPH. They don't follow the action line, and they don't follow the books. So they deliver rapidly. What we call precipitate labor in the central hospital may not actually be precipitate labor for the people here. So I don't know, we're still carrying out the study to find out what really happens. Some of them, they accept that they've been taking these motifs, and the others will refuse, but still their labors are really rapid. And we feel probably something in the Zambezi water that is contributing to their patterns of labor. I've just put 2 here to demonstrate what I'm talking about. This is a woman who came in labor. It said the labor started an hour earlier. And when she came in, she was already 7 centimeters dilated. Within 2 hours, she was fully dilated and delivered. So this was a multiparous woman. The next one, this is a nulliparous. This was a first pregnancy. She came in labor, and again, within 3 hours, she had delivered. So this is the standard that you would see in most of the partograph. If you go into the labor ward at Victoria Falls, this is actually a patient who has delivered this morning. This is 3 September. So around 4 a.m. So she had a first degree TIA, which was repaired. And this one is but the APGAR scores, when you look at the APGAR scores for the baby, there was 910 to 1010. And this one is a nulliparous. She had the same rapid progress of labor. And she, probably not very clear, but the APGAR scores for the baby was 510 to 710. And she had an episiotomy done there. So basically, this is the type of partograph that you meet in the labor ward every day. And the woman who goes for more than 6 hours in the labor will be called by the sister to say, we have a slow progress in labor. So it's really interesting. And we realize, probably this is the medicines that they're taking from home that is contributing to this kind of pattern. And we want to do, we're doing further research to find out how this is impacting on the fetal outcome, maternal outcomes. Then I'll go on to talk about the clinical mentorship. So we have a clinical mentorship that is going on nationwide. So it was initially central hospital consultants going out into the provinces to assist the GMOs and DMOs to manage obstetric and gynecological emergencies. And then provincial specialists doing the same. And now we have the specialists that are in the provinces and the districts. And so this national program is also being conducted in Matabele North. So at the hospital, we do on-job training for the doctors that we have at the hospital in Victoria Falls. Then we also conduct monthly visits to all the district hospitals in rotation, where we mentor them at their own stations. Then we have quarterly visits by DMOs in rotation to Victoria Falls hospitals. At the moment, we have 3 doctors from the province, one from Cholocho, one from Kai, and another from St. Luke's in Upane, who have been attached with us for the last 2 weeks. Some of you may have seen them presenting on Zoom, some of the cases that we give them to present. And it's really benefiting them, and we are happy that we have impacted skills to them to be able to handle obstetric emergencies and gynecological emergencies. And this project is quite impressive in that they are really eager to learn, and sometimes they actually inform you that we never got the opportunity to do these procedures when they were still SRMOs. So now that we are in the districts and provinces, we are trying to impart the skills on them. This is one SRMO, not SRMO, now a GMO, where we had the cesarean section for a clamp and a uterine atom. She's the one who was doing the procedure, and I was just assisting. So here we can see that the uterus was really bleeding, and the uterotonics were given, and it didn't respond. And you can see even the swabs here were really soaked as the patient was bleeding. So we had coached her on how to fashion a billing suture, and she managed to do one successfully, and the patient was able to survive. And we didn't need to choose this patient. So this is one of our doctors from the province who had come for the mentorship. Here's another one. Now here, you'll be surprised. This one here is a clinical officer who's working at Victoria Falls Hospital. This is also a clinical officer from Kai who had come for mentorship. So now this clinical officer had been taught how to fashion a billing suture, and she was now teaching also another clinical officer who successfully did their own billings. So we are really happy that we managed to impart this skill to our doctors, and we the majority of our doctors in the province can now do this procedure. So it's really life-saving, and it preserves these uteruses for the patient that may end up with a hysterectomy. So we are really happy that we've managed to do this. Achievements, so DMOs, GMOs, clinical officers have been trained in managing obstetric and gynecological emergencies, and we are really impressed with the output that we have seen. The majority of them now can do ectopic pregnancies without having to refer them. So they can do ectopic pregnancies without calling even the specialist. They are now able to do 2 previous cesarean sections, and they are no longer reserved for the specialists, and they are no longer being transferred. So for me, I'm now doing the previous and above. 2 previous, even the clinical officer can now do this one. So we've really done all these cases, and we've managed to impart the knowledge to our doctors. We've done the medical obstetric and gynecological procedures, including TH, myomectomies, successfully at our institution. Overall, this has reduced the provincial maternal and perinatal morbidity and mortality. What are the challenges? So as everywhere else, we have challenges with equipment. I'm one person who's really in love with laparoscopy, and I really feel disadvantaged when I'm not able to do this because we don't have the equipment in the district. So we've lobbied with the government, we've lobbied with the PMD and the head office for us to have a laparoscopy tower. I was requesting if we could have even just the tower to do diagnostic laparoscopy. Even one which is lying redundant at perineal, if it could be sent to us, would be really glad. We now have the machine for lip, but we still need the colposcope, and we still need more loops for us to be able to do sufficient lips. In terms of human resources, so we only have one specialist. We need more of the obstetricians to come to Victoria Falls. And we need a pediatrician, a minimum of 1. We also need an anesthetist, physician, and OTN. We need more of these ones and more of the midwives. I'm glad that very soon we're going to have a physician. One will be coming towards the end of the year, and that will be really impressive as it will help us co-manage patients with the medical conditions in pregnancy. We have challenges with drugs. We have challenges with surgical sundries as well. And sometimes we are forced to ask patients to contribute, probably say sometimes they buy their own gauze, they buy their own abdominal swabs. So one thing or the other is always out of stock. So we really feel this is a major challenge that then reduces our efficiency to offer these services. Blood and blood products. Yes, we have our lab, which is blood, but it's not enough. And we realize sometimes we don't have the platelets or FFPs, and we are forced then to transfer such patients to Bulawayo because we don't have those products. And then remuneration, we feel that it's not adequate for the specialists and definitely for the rest of the cadres that are working in the province. Another challenge that we face with the impact with the advent of COVID-19, it has really had a negative impact in terms of our care for the patients because many things are now restricted, and some of the procedures, including outpatient services, have now scaled down. So some of the things that they have wanted to do have now been curtailed because of COVID-19, and resources being channeled towards COVID-19 means even more negative output to the rest of the chain. So recommendations that we want to leave is if we can allocate more resources to capacitate provincial and district hospitals so that they can efficiently provide specialist care. We need to incentivize the specialists so that they will be able to accept decentralization. by way of remuneration, by way of providing them with vehicle schemes, by way of providing fuel for them, and good accommodation to all these cadres that will be working in the provinces. Yeah, we feel that there's need to unfreeze all posts at all levels. Quite a huge challenge in terms of sending out specialists to the districts and the provinces, because you find we have gynecologists who want to come to Victoria Falls, but they're always told there's no post. So this is something that we really feel should be taken up with the ministry, that for this decentralization to be a success, we need to unfreeze posts and create posts so that we can have specialists and that are able to get posts in all the provincial and the district hospitals. So that's a very important point there, because we have quite a number of people that are failing to then come to us, even though they have the will to come, a desire to also offer their services to their provinces, but always find blocked by the issue of posts. Definitely, there is private practice, so you should also be able to feed your family, since the government is not adequate. So yes, I managed to have my own rooms at Chinotimba Med, it's a 24-hour center, and I have my consultation rooms there. Also do deliveries there. Another private hospital which is in Victoria Falls. So we have two private hospitals where we do deliveries, and then the government hospital. Then we have also Premier Medical Service. We have another GP in the town, and we also have CIMAS. CIMAS is opening up very soon. And after the mentorship, we always try and steam off, wine and dine. Thank you. That is the end of my presentation. Thank you.
Thank you very much, Dr. Nyakura. I'm not sure that Dr. Matega able to continue, because he said his internet was on and off. Okay, so maybe I'll finish off sharing the meeting. Thank you very much for the stimulating talk. Well done for the tremendous work you are doing. I'm sure there'll be lots of questions and comments from the audience. Please, Dr. Njikisana, I can see your hand is raised. Please go ahead.
Afternoon, colleagues. Thank you, Dr. Nyakura, for that presentation. Very interesting and very stimulating. I having come from the district at some point. I found at least your study must be interesting. The one on perinatal outcomes in terms of use of uterotonics. Dr. Ziki did her dissertation on that. She also had her own findings, which I can't immediately call to mind. I was curious though, which women you're delivering? Since most of them seem to have precipitate labor, what are the referrals for them to actually deliver at your hospital if they are actually progressing so quickly and having good perinatal outcomes? Thank you.
All right. Thank you for the question, Dr. Njikizana. Yes, Dr. Ziki did a similar study, and we would also want to compare our outcomes from hers. So the majority of our patients, district hospitals, they are supposed to get referrals from the clinics. However, in Victoria Falls, some of them are not even referred. They just come, and we manage them as they come. We don't chase the patients away. We have a city clinics in the town, and these have actually charge patients for deliveries. So some of the patients will actually try and avoid going to the clinics to avoid paying. So this user fee has moved the patients to come even when they don't have complications. And then we have patients that have complications that are really genuinely referred from the clinics and from the surrounding district hospitals. And these are that's our catchment area. So as catchment area, including Bing and all the other districts that are close to us. So you realize we really don't restrict the assessment to patients that are referred genuinely to those that have come on their own. So yeah, there's no restriction in terms of are they genuinely coming to deliver at a district hospital or they should be delivering at the local clinic. I hope that answers your question.
And Dr. Maua was also raising his hand. Dr. Njikizana, you answered?
I'm answered, thank you.
Thank you. Dr. Maua, again, go ahead. Unmute yourself. Is Dr. Maua still on? He might have dropped out of the meeting. Then there is a comment from Dr. Mapanga. Is there a limit to what OBS or gynae skills that can be taught to GM or clinical officers? I think these are specialist obstetricians and gynecologists. Probably this is a question to everyone, isn't it?
I'm sure that's a question to everyone. To say, can we allow a clinical officer or a GMO to do a billing? Yeah, probably that's one. So for me, yeah, I've said I will have, yes, definitely there are limits. you cannot expect a GMO or clinical officer doing myomectomy, TAH, and all. And even the ectopic pregnancies, if it's an abdominal pregnancy, we cannot afford to risk by allowing those cadres who are not well trained to do them. So there is a limit to the cases that they can do, but we want to inculcate them skills that will be able to save lives. So all the skills that we are giving them is those that will allow them to be able to handle obstetric emergencies and gynecological emergencies.
Is there a comment on this same topic? I know in particular for the GMOs, they can always be trained to do anything. The problem comes if they do something they are not yet confident in, and then a complication or it results in a complication. Then they are judged at the specialist level. But I think you are well justified in training them because it does save lives, given maybe potential transport issues and other logistical problems in getting them to where you are. Do you have another comment? While I'm waiting for another comment, yeah, thank you for training the SRMOs in increasing their surgical skills. Maybe we just need to forewarn you that maybe you'll be getting SRMOs who need more help because there's hardly much training happening at the moment. So I think the SRMOs you get maybe from next year really have to hold their hands and take them from the basics, right from the start. I know at the moment they are the ones on the ground, so they are probably doing most of the work alone without much training. There's a comment here. Okay, there's a comment, somebody encouraging you to look at the perinatal outcomes, which you say they've not really improved. But I suppose this is impacted by many other factors as well. So it will be difficult for you alone to reduce this outcome.
Yes, definitely. We have looked at our provincial meeting and we have said, yeah, we've been really successful in reducing maternal mortality, but the perinatal impact has not been very impressive. So yeah, we are looking at it. And one of the things that we came up with was we really need a specialist pediatrician to assist in terms of managing the cases. So we really need that to have an impact. So it's just not that the human resources, but also have the material sundries that are needed in terms of drugs. We need to give dexamethasone to our patients with threatening preterm labor, and those that are delivered electively or as an emergency because preterm because of a complication, one complication of or another, preeclampsia, eclampsia. So we need to be able to give steroids. we need to be able to give a surfactant to those babies that are delivered preterm, but most of the time we find these resources may not be available, and that has contributed a lot to non-movement in the perinatal outcomes.
I don't see any hand, so I assume there are no more questions to ask. So Dr. Nyakura, once again, want to thank you for the service you are doing, and hopefully be able to get somebody to come and assist you in the force. And in fact, this is also a stimulus to other young gynecologists who might want to find another district where they can settle. Thank you everyone who have been able to participate in this meeting. So bye-bye.
Thank you. There's a question here which says, let me just answer, who anesthetizes your patients? So yeah, we have the nurse anesthetists who are well-trained and experienced. And I'll tell you, I've never had a wonderful time with anesthetists as I have had here compared to what I had in the central hospital. These guys are very efficient, and we have not had any anesthetic complications we have now been here for over 18 months now. So we really are happy with them. But of course, they have also their limitations in cases which they cannot handle well. They always call their consultants in Bulawayo and Harare. And there's one consultant who's always helping them, Dr. Gore. He's always on the phone with them and assisting with the cases that are difficult for them to manage. But definitely would need an anesthetist to be here, a specialist anesthetist to be here, assist with the nurse anesthetist. So the whole province is nurse anesthetists. At Vicfors, we have 3 of them who are well trained, and the whole province is nurse anesthetists that also help a lot. Most of the cadres here, they've been here for a long time and they are experienced, and they can put to sleep any patient.
Okay, thank you very much. I think with that last question, we can end the meeting.
Thank you, Dr. Mazire. Thank you, everyone, for attending.